Well, good afternoon, everyone. Thank you for joining us to hear a panel presentation about COVID-19. Dr. Bruce McNulty, the Swedish Hospital's Chief Medical Officer, and he's going to provide a summary of Swedish Hospital's response to COVID-19 pandemic, followed by questions directed to our panel. I'd like to ask that each of you mute your mute button during the presentation, and if you have a question, please enter it into the chat feature in the lower right area of your screen. So thank you again for being here today. It's great to see everyone, and I will now turn it over to Dr. McNulty to start the presentation.
All right, thank you. Hi everybody, appreciate you joining us this afternoon. I think I know most everybody who's listening in, but I'm Bruce McNulty. I've been at Swedish starting in 2001, and I've been practicing emergency medicine since 1989, so a long time, and the vast majority of that time here in Chicago. I'm getting towards the end of my career, not quite at the end, but I had, as I transitioned into the Chief Medical Officer role from the emergency medicine role, I felt grateful that I had managed to avoid some of the worst things that might happen as you lead an ER, right? So the heat wave that we had in Chicago in the summer of '95 probably was the toughest short period of time that I'd experienced as an emergency room physician. And I was grateful that we never had a pandemic or a major disaster in the city, but I spoke too soon, and COVID-19 hit. In early January, reading online New York Times, seeing about this outbreak in Wuhan, and wondering, you know, is this the one that might do more than SARS and MERS had done, and might, and Ebola, and might actually come to Chicago and impact us? Kind of followed the story pretty closely. And there was a point in the story, I'd say towards the end of January, where, as you may recall, there were several cruise ships out and about that had victims, and the disease was clearly spreading. And no country really wanted to let, you know, these cruise ships dock for fear of what might happen. And the leader of Cambodia made the decision to allow one of those boats to dock, and those passengers, many of whom had the disease, to disembark. And I remember reading a phrase from a public health official that this will now be like stopping the wind. And at that point, I was pretty certain that we would be impacted by this disease, and certainly we and every corner of the globe has, in fact, been impacted. Today's presentation is to tell you a little bit about what's been going on at Swedish. I was going to start with a very, very high-level overview of just the numbers. You know, many of you may be familiar with these, so we'll go over them quite quickly. And then the questions to our panelists were driven by you guys. So we asked for questions, and many of you submitted them. And I looked through them and directed them to the folks here at Swedish that I felt were most appropriate to answer those questions, often because they helped lead the response here with regards to how we tackled the problems that you asked about. So if I get the first slide, you know, pandemic globally, and these are from about a week ago. You know, U.S. is now over 5 million. You know, deaths of 160,000. Most people would say those death counts are underestimated. You know, we had the experience here at Swedish where a variety of people, especially impacted by you know, hypoxia, that some people termed a silent hypoxia, or lack of oxygen, came in as cardiac arrests of unknown origin. So, you know, sometimes we were directed to test those patients, but not always. So if you look at baseline deaths in the country and in states, and then what happened as the pandemic hit, the numbers are higher than that. Top 5 states you can see, Illinois is not amongst them. Again, given that we have the 3rd largest city, it's nice that we're not in the top 5 states. But we really have one big city here. Certainly those states that have more big cities seem to be at the top of the list. So we are currently 7th. Again, I think dealt with it reasonably admirably as a state and as a city so far. Next slide. U.S. Again, we are the top country in the world, unfortunately. You can certainly have a lot of conversation about why that might be the case. But with about 4 to 5% of the world's population, we have a disproportionate number of the world's cases, as you can see from those numbers. And certainly, we are the most industrialized country to have those kind of numbers. Next slide. There's a number of ways to look at the numbers, but positivity rate is one way you look at kind of how impacted an area is. Illinois is 38th on the list, so we've got about a 4% positivity rate now. So what that means, again, is people who come in and get a swab done, what percentage of those test positive. As you might expect, there's a number of reasons why you might be doing a test. At the beginning, the most common reason is you have some kind of symptoms making you suspicious. A lot of people in Illinois and elsewhere now are having the test done for other reasons, like before a procedure, or perhaps going back to college, or perhaps being a professional athlete. So a variety of reasons why someone might have a test now that can impact that positivity rate. Next slide. Again, statewide, pushing 200,000 cases, 7,500 deaths, 95% recover. So again, there are those that aren't recovered could still be in the hospital. Mortality rates typically about 1%. Next slide. Chicago, again, about 62,000 cases, about 287 a day. Our positive rate about 5%. We would like to keep it below 5%. And our zip code is about 5.5%. And again, what we found at Swedish was that our neighborhood was disproportionately affected during the first wave of this pandemic. A whole variety of reasons for that, and we'll get into that just a little bit. But at one point during the pandemic, our hospital had the 4th most inpatients, behind the large academic medical centers, Northwestern, Rush, and University of Chicago. Swedish Hospital was 4th of impacted hospitals. Next slide. So again, this just gives you kind of an overview of some of the ethnicity. So total number of confirmed cases, again, the 709 is patients who were admitted. 159 patients died from this disease. 318 were discharged home. The rest were discharged to long-term care facilities. And a disproportionate share of Hispanic patients compared to what is in our neighborhood. Is there one more slide? All right, okay, and again, this is just a view of total number of patients in the hospital. PUIs is a term that we use for patients under investigation, so patients who are tested and those tests are pending. So certainly, as you can see, just a nice downward trend. Might be ticking up a little bit again, but again, what we're seeing in the hospital right now is 8, 10, 12 patients in the hospital at any given time. So far fewer than the 120 or so that we had at our peak. So with that, I'm going to get to questions that that those of you listening have submitted. I'll tell you a little bit about the panelists who are going to answer those questions. So we're going to start with, and I think everyone has a copy of this, but Dr. Tommy Dang is a family medicine physician. He actually trained through our family medicine program here at Swedish. We have a variety of medical education programs. Tommy graduated in 2019, so just a year ago, and joined the Swedish Medical Group. Dr. Dang really jumped in terms of helping us figure out how to get people in the hospital and tested, without necessarily setting them into offices, ER, or other areas that might be otherwise impacted. So a couple of questions that came through that would be ideal for Dr. Dang. Tommy, can you talk about the different testing options? Some results seem, we're reading that they'll come back in a few minutes. Others are 24 hours or more, and then you hear some stories about tests taking 2 weeks. What's the disparity in terms of how long they take, and is it related to accuracy of those tests?
Sure. Can everybody hear me?
We can.
Okay, perfect. So, we're fortunate in the sense that we have support from the North Shore system in terms of our testing. What we're allowed to do, or what we can do with their support, is that we can collect a variety of testing for COVID. The two major options include our drive-through. Our drive-through is set up so that, a patient can literally drive up to the drive-through, roll down their window, and have an oral pharyngeal swab collected. This oral pharyngeal swab comes with a pretty high sensitivity and specificity. And just to give a quick clarification regarding that terminology, sensitivity is the accuracy of a negative test, and specificity is the accuracy of a positive test. So for an oral pharyngeal swab that you'll receive through our drive-through, we're looking at a 97% sensitivity and a 99% specificity. And those are, really great numbers that we're working with. There's also, real quickly, for the results to return from that oral pharyngeal swab, traditionally, it's been about a 24 or 36-hour turnaround time. And that's been great. And I won't speak for other systems because I'm not familiar, but I've heard the return time for some of the other surrounding facilities to be much longer than that, some up to, a ridiculous time of like 7 or 10 days before labs are actually returned. So the fact that we're able to get labs back so quickly, it makes our response to COVID much more effective, and really makes communication to those patients very efficient as well too. The other option for testing is through our what we call a rapid viral panel. This is reserved for a very unique situation that demands a COVID answer very urgently or even emergently. The result comes back in about 45 minutes or so. And the sensitivity and specificity of this respiratory viral panel is very similar to our oral pharyngeal swab. We're talking, again, a 97% sensitivity and also around a 99% specificity. So those are the two major options for COVID testing.
All right. Thank you, Tommy. So, one of the things reading between the lines here is we still live in a world of, unfortunately, some limitations of our testing options. So, again, Dr. Dang alluded to the fact that we are very fortunate to have entered the North Shore relationship when we did, for a whole variety of reasons. But one is that they were early in their ability to run tests here in the Chicago and in the nation. But the test that we send to North Shore is a 24 to 48-hour turnaround time. There are some rapid testing options. They are of variable sensitivity and specificity. We have one that is quite good, but again, there are severe limitations in the supplies of that test. So we use it in very specific circumstances where it's imperative that we have a test result right away. So again, it will be great when we have a rapid turnaround test that is accurate, that we have at our fingertips all the time. That is not the situation now, and it's really hardly the situation at any facility. So Tommy, how about the antibody test? So the test you discussed is one that tells you that you are currently infected. There's an antibody test that's been, people I'm sure have heard about. How reliable is it? If it's positive, are you immune? Does it mean that you're immune forever? And how about the possibility of reinfection? Is this something that you are protected forever if you're antibody positive, or is there some uncertainty there?
So that's a great series of questions, and I think some of those questions are still under investigation. But just some of our preliminary answer, our antibody test that we run through our hospital, it also comes with a very high sensitivity and specificity, nearly 99% and above for both categories. Now, traditionally, when you develop antibodies to a certain disease, the understanding is that you are immune to that disease. Our antibody test has come with a little bit of a disclaimer. It says very clearly that it's unclear whether a positive serological test indicates positive immunity or protects against reinfection or cessation of viral shedding. I think the reason why we have that disclaimer is that we just don't understand this disease well enough, and we haven't had a chance to study it long enough to conclusively say and confidently say that these antibodies will remain in our system and that we are immune to it moving forward. I've heard of some anecdotal cases where a patient was initially tested and was positive for COVID. They later on tested again for COVID. It was negative. For other unknown reasons, they developed symptoms again and decided to get a third COVID test. And that third COVID test was positive. So I don't know how to explain that particular situation, but at least the current understanding and how antibodies traditionally work is that if you develop a disease and you develop antibodies to it, you should be immune to it in the future. But again, I think that's going to be, for us to be able to confidently say that regarding COVID, there's going to be some additional studies that are needed.
All right, thank you. So last question we have from our group is one that is brought to us commonly and one we've grappled with our employees as well. So if you believe you were exposed to someone known to have COVID-19 and you're concerned that you might get it, do you wait until you have symptoms to get tested, or is there a certain time after exposure that you could get tested to really tell yourself, no, I didn't get it, or yes, you did, and take those appropriate precautions so you don't spread it further?
Yeah, so that's another good question. The best route of going about this is waiting till you do have symptoms after exposure. And the current studies, at least there was a recent article released by JAMA, the Journal of American Medical Association. They recommend waiting until like day 5 to day 7. That's typically when symptoms will develop, and also that's also when you'll get a positive test. So, if you were exposed to somebody on day 1 and you got tested on day 2, two things. One, you probably won't have symptoms quite yet, and also 2, your test is likely going to be negative because it hasn't been able to pick up those viral particles yet. So we do recommend waiting until symptoms develop or until that 5 or 7 day mark to consider testing for yourself after exposure.
All right, great. Thank you. That's very helpful. All right, our next panelist is Kim Leslie. Kim, I think you are in the leadership room, so we're going to have to flip that camera back towards where she is. So Kim is our longstanding nursing director of emergency medicine. So Kim and I worked together for a number of years leading the ER together, which was a total pleasure for me. As you can imagine, we always look at the ED as the front door of the hospital. And for our COVID response, Kim and our ED director, Carrie Robertson, stepped up in huge ways to help deal with the true wave of patients that came our way while trying to maintain a safe environment for our other patients. So Kim, can you describe how the ER prepared and changed in anticipation of COVID during the first wave of the pandemic?
We made a lot of changes, and it was only because of the support of administration and the rest of the hospital that we were able to meet our goal of caring for as many patients that would need to come to us at any given time. We had support of a float pool from the rest of the hospital when other areas were reallocated, and some of the float pool staff had never set foot in the emergency department, and our goal and mission was to cross-train them to be able to take anybody's position if our staff would succumb to the disease. Because of the cross-training, we were always able to have our full staff ready and available to care for patients. We also converted one of our pods, Pod B, to a respiratory ward. So we installed doors, and respiratory symptom patients would go to that ward to try and keep dirty, clean area of the emergency department Later we realized and we learned and were able to evolve that this is sneaky and not everybody has classic symptoms. It wasn't as easy as putting them on one side of the door or not. We also converted our behavioral health area, our 4-bed area, to a makeshift intensive care area if we would need additional intensive care beds. ICU more than doubled their capacity and their patient volume during this time, so we infrequently had to use it. However, we were prepared there with some structural changes, and we also had the anesthesia department housed in our behavioral health area temporarily. So they would help support our airways as often we were intubating because somebody had respiratory failure, 2 patients in every pod, so we needed their expertise as well. We appreciated not having visitors at the time. We needed to gain control of what was going on, who was exposing who. If I would bring in a loved one and the loved one is sick, chances are I might be sick, so now it's double the exposure to our staff, and we needed to keep everybody healthy. We also changed our staffing such that once you came in, sometimes in the emergency department, you would switch to different pods, triage up front, different roles. Everybody stayed where they were at and worked with the same people over and over. So if there would be potential exposure, it would be limited and not wipe out our whole department. We had weekly press conferences, one at night, one in the morning, that we held to update everyone on the ever-changing guidelines and share with them the availability of PPE. There were some concerns there wasn't enough, and fortunately we always had enough, and that reassured staff to do the job they needed to do. With the press conferences, we said no questions, be aware that things are going to change. We also had one marker board, and instead of posting things up or sending things out and you're not sure is this current, everyone was to look at the marker board by the charge nurse, and that is what you should wear for personal protection. That's what you should swab with. That's what our statistics are. That's what our available ventilators were, and that was very helpful. We stopped EMS at the door, so every ambulance patient that arrived would stop at the door, and we would make sure that the crew and the patient were masked before they entered our department, because we really had to keep the integrity of our department as safe as we could. We also adopted a motto of slower, safer, be a little smarter about how you run in. While we weren't necessarily the television show ER or running in, we did tend to all run in and jump in with a critical patient, and now we realized that that was potentially exposing everyone, and we could do it smarter and more safely with fewer people if we assigned the roles ahead of time. So we would have designated teams to go in and manage this instead of everybody normally running in, as you would see. Also a huge help was the ICU being able to take as many patients as they did, so we stayed available to help patients. So a lot of changes, many are still in place, and everyone knows that it's ever changing, and to stay current with what's going on.
Great, thank you, Kim. So, you know, during the toughest days in April and May to today, you know, how has COVID affected the volumes, the census in the ER and in the hospital overall, and why do you think it's impacted things the way it has?
We have tended to see fewer quick care patients. So patients who would say, oh, I don't feel so well, I hurt my finger, I hurt my foot, I've had a headache, I can't sleep. Those patients we've noticed are not seeking treatment, both from their primary care physicians and from us. For whatever reason, they may still have a perceived notion that they would be exposed when the opposite is exactly what is the case. We're more afraid of the public exposing us than they need to be from getting exposed to us, because we have such safe measures in place. Our census might be down, however, the acuity is up. We are still admitting about the same number of patients, which is a greater percentage of our patients, which represents that they're sicker when they come in. Perhaps they haven't had medical treatment as they should to maintain their health over the last few months, or perhaps they just are coming in now that they are ill, and they've given in to the fact that they need our resources. It's nice to reassure them and to get them back in their state of health, and the admissions as a result are up because of that.
So just to add to that, I think, again, many people may have read this, but, you know, since March, nationwide, the number of cancer diagnoses has dropped pretty dramatically. The number of cases of appendicitis has dropped. The number of people diagnosed with heart attacks and strokes have dropped. And unfortunately, those diseases haven't gone anywhere. COVID is not a cure for cancer, appendicitis, or stroke. So, what it tells us is that, people's fear of going outside and accessing the healthcare system is overriding going to get care when you really need it. So this really is a public health issue that, education is going on nationwide to try and reassure patients to just what Kim has said, is that, hospitals have learned quite well how to adequately prepare and keep patients safe who access our systems. And putting off care is far more dangerous than coming in safely to hospitals nationwide and getting the care you need. Kim, a question regarding flu season coming. How could a patient tell if they have flu versus COVID-19? And what can patients do to try and protect themselves from either of those infectious diseases?
I'm hoping everyone has learned going into flu season to wash your hands, wear a mask, stay home if you don't feel well. There's no such thing anymore. Just like we changed to be a little smarter, slower, safer, there are no heroes coming to work sick. Do yourself a favor. We would rather work without the help, especially in our setting, than have you come in ill and get several others sick, whether it be COVID or the flu. Certainly we want to know what we're treating if somebody has COVID or the flu. However, the management is going to be similar. So patients can reach out to their physicians if they can't manage it at home with fluids, rest, acetaminophen. Certainly we're here if somebody has respiratory symptoms or is not turning the corner and getting better after a few days. We would like to evaluate them so that they will have a better idea what they're dealing with. And we do have the ability to test for what is out there between laboratory tests and our clinical evaluation of patients. Perhaps it may not be COVID or the flu. Perhaps it's something else. So we're available for such. I hope that everyone heeds the warnings and that whether it's COVID or flu or anything, that people are healthier this fall.
Great. Thank you so much, Kim. All right. We're going to move now to Dr. Kate Maxuris. Before I introduce Kate, I just wanted to kind of commend the foundation donors that are there on the caliber of questions that you guys submitted. These really are, outstanding, very thought-provoking questions, and it's really been fun to think about them and to provide, our best educated answers to you in response. So thanks for taking the time to submit these. So Dr. Maxuris wears so many hats at this organization that I'm surprised you can stand, Kate, with the heaviness of your many hats. We were lucky enough to poach Dr. Maxuris from St. Joe's many, many years ago. She works over in the Foster Medical Pavilion, seeing really a large panel of incredibly devoted patients. And in addition, she has two other huge responsibilities here. One is overseeing our managed care organization called Swedish Physician Partners. And the other, which became, as important as any function in the hospital during this pandemic, is overseeing employee health and making sure that our employees were safe. We absolutely had employees contract this as we learned about how to protect ourselves and also out in the community. And Kate really carefully guided us through that very, very complicated endeavor of our employee health. So, Kate, the first question from our listeners is about schools potentially returning to session. Can that be done safely? And if schools return, what kind of equipment, procedures, protocols might be necessary to actually bring school back safely?
So hi, thank you, Bruce, and hello to everybody. So of course it is a very difficult question. We know that instructions or teaching in person, especially to younger population, is crucial for their compliance, for their listening, for their ability to learn, for social interactions, for developing different skills. However, we start weighing the lesser danger maybe, and that's when we need to start thinking, is it safe in the current situation at all? I believe that back in March, when the CPS and other schools decided to rapidly shut down and go virtual, they had probably played a crucial role in ability to bend the curve in the state of Illinois. It took us still multiple weeks, but we were able to get it down to 2-some%. And then we started to reopen, and we see what's happening with the positivity rate with that reopening. We are very steadily climbing up. We're at about 4.1 to 4.2% daily, which is still in the safe level, but this is a result of very controlled reopening. My worry is that if we start sending kids to school, you know, the two games that are going to happen, let's swap the masks, right? You have a nicer mask. Let's switch them. And then, of course, the kids that want to keep everybody interested, you know, everything interesting, that are going to be pulling down the mask. Oh, look, the teacher didn't notice. I'm going to spit on you. I'm going to cough on you. You have COVID. So that's going to be a great source of exposure. I think the schools are realizing it. And as we heard maybe 9 days ago, CPS, after planning this hybrid model, suddenly went into complete shutdown. In my opinion, I think we need to sit it out for another quarter. Is it possible to do it right? Probably in some circumstances, with daily temperature checks, with separating those kids really 6 feet distancing, with very good kind of control that they are wearing the mask, that they are not getting in touch with each other. That's going to be a difficult enforcement, especially with the younger children. I am not sure how much the hybrid model where the kids are going to school half day twice a week, because these are the hybrids that were planned. If this is going to really bring to those kids enough benefit to risk the infection. So I think the schools are leaning towards closing down, and I think until we have a better handle on it, or even the vaccine, I think we should be all sitting it out. So I have a lot of questions. I have a huge pediatric population, probably about 65% of my patients. I get daily questions from the parents, should we send the child in? And as I say, although there's no, direct contraindication, I think it's not, if parents can afford, are able to take care of their children at home, I think until probably New Year, we're going to be sitting it out.
Kate, I'm sure you've seen the same articles I have over the last number of months of kids don't get this, kids do get this, kids don't carry the virus, kids are loaded with the virus.
Starting from our president.
What's reality?
Very strong statement about kids not getting it. We truly have a low number of confirmed infection. I think I read somewhere the statistics that we have 4,000 of kids with confirmed infections out of 5 million of confirmed infection in the US. So it appears that kids are getting maybe it less. Also, kids are going to be more likely to have a mild cold, runny nose, maybe decreased energy, maybe some sore throat, maybe they will vomit twice. We also know about Kawasaki-like syndrome that was reported in clusters that would put those kids in ICU on ventilators, and that was becoming very dangerous infection. So it appears that, yes, kids will have lighter form and maybe less frequent, but let's remember, the country went into the shutdown in March, and really kids were the most sheltered because the parents would go to work, the parents would go to the store, the kids were mostly kept at home. We also have to remember what's going to happen with the child that gets exposed, gets infected, maybe has minimal symptoms, and comes in to the 3-generation home where there's a grandma that has asthma and grandpa that has a heart disease and parents with some comorbidities. So I think those kids have the chance to become super spreaders. So as they are less likely to have severe disease, I think we need to be looking at the, what they're going to do to our society.
How about college dorms? Kate, there seems to be even more variability there.
Yes.
U of I is going back, DePaul is going back, North Park's going back. Many others are not. Harvard is not, Stanford is not. So, you know, any thoughts, you know, if someone has, you know, you've given your opinion about schools going back in general, but if someone has a teenager going back to a college dorm, what's your recommendation there to try and minimize their exposure and their likelihood of bringing it home at Thanksgiving?
Right. So again, it's the difficult situation, and I know that the universities have made a tremendous effort, you know, to create single-use rooms, there's less students to the bathrooms. They need to stay in the rooms for instructions, also hybrid models, as those hybrid models were kind of encouraged. A lot of schools are going virtual. Loyola had the option of choosing of virtual classes versus hybrid model and some classes in person, and they rapidly, last week on Tuesday, the message went out, there's no in-person classes at all. The same they did with the dorms. They were preparing to house multiple kids, and they rapidly announced on Tuesday that they will not be bringing any children to the dorms, and the decision was based on counting up that they would receive 700 kids from the hot states, where they would need to quarantine them. And of course, freshmen or kids coming to college, kids feel immune to the disease. So quarantining them is going to be, you know, will be questionable. If you have a responsible teenager, if you can say, you know what, you're going to really sit in your room, do virtual classes, I think it's reasonable to go, but is there a sense to go, right, if we're going to do everything from home? But it's also a heartbreaking message to the teenager that has been waiting throughout a couple years of last high school that they're going to go to college. So difficult decision. Again, I think it's more reasonable, but you have to be able to trust your child that they will make good decisions. You know, we just heard about the 23-year-old from Northwestern, probably everybody had seen it on the media, that landed in Northwestern ER sometime in April, had 15 or 20 minutes to call her family before intubation. She said then she had nightmares of drowning. She thought she's waking up in the in April still, woke up at the end of June with new lungs after the lung transplant. And that was also a young person. So I think, again, as much as we can keep those kids away, and especially with ability to virtual learning, I think it's reasonable to do it. Even if we are going to lose a year of education, of quality education of all the kids in America, but we're going to save 20,000 kids from dying, I think it's worth it.
All right, thank you. So this certainly became pertinent for our employees. If a person tests positive, how long are they contagious, and when can they safely return to work or be around their family?
So, of course, it's for employees, for anybody. It's a very new disease that we have a very little still information about. You know, it's been around for a good 6 months or 8 months. And those recommendations have been changing. As we walked in March to the disease, the CDC was stating 7 days. If the symptoms are improved, they're fever-free for 3 days, they can go back to work. That was a couple months extended to 10 days as the studies were done, and they showed that significant number of patients are still contagious at 10 days. Just recently, maybe within the last 2 weeks, the CDC made another update. 10 days for the regular severity of disease, and for those considered to have a severe disease, they should be quarantined for between 14 to 20 days. So for our employees, what we have made the change is, for those that get hospitalized with significant treatment to it, we're keeping them out for 20 days. And that's a recent change. So anywhere between 10 and 20, probably at least 10, if not 14 days for general population.
So Kate, final question. You know, both employees and community members, how do you stay safe? What's the advice that you give to your patients and our employees about how to avoid contracting this disease?
I think that the science knows it, and we tried it out in Swedish, and that's when we got a handle on everything, is when the mask order went into effect. This is when our employees stopped getting sick, and we had actually a streak of amazing, because sometimes a couple weeks where nobody was getting sick. So I think the community is mask all the way. One person with mask is not enough. Leave the places where people are without masks. I keep walking into gas stations. I keep walking to Costco. There's people with masks hanging, and nobody, the public, is walking by them and not making any kind of comments. And I think until we get that message that we have to stay in masks, we're not going to control the disease. And of course, reasonable interactions, right? The fact that you can have parties up to 50 people in the room does not mean that you have to have that party of 50 people. You know, there's going to be still time, you know, social distance and consistent mask wearing.
All right. Kate, thank you so much for those answers. Very much appreciated.
Thank you, everybody.
Our next guest is Robin Brief. Robin's AVP over critical care. Critical care just came through in really the most unbelievable way and was so impacted. And really, I have to say, I think the staff there, probably took the greatest, I'm going to use the term, emotional beating of anyone in the hospital. Patients that made it to critical care were deathly ill. Many did not survive. And as was alluded to, for the safety of our community, we had a no visitor policy that really meant that those nurses who, amongst their greatest skill, next to their incredible nursing, is their ability to connect with families and comfort them at times of grief and loss. Was over the phone, was remote, and it's tough not to hug people at their toughest time. So, of all the people that personally my heart went out to, it was Robin and her team taking care of our sickest patients at one of the most difficult times that you can imagine. So, Robin, I will always be grateful for what you and your team did for the hospital and for the patients and community. So, at its peak, talk about our ICUs, how they were impacted, and how we responded, if you would.
Sure, thank you. Our ICU currently has 14 beds. We have a step-down unit that has 16 beds. During the peak, the surge of COVID, we more than doubled our census. We went up to 39 critical care beds. Well before we hit the surge, Dr. McNulty, Kathy D'Onofrio, and Anthony Guacho got us together and said, hey guys, this thing is coming. You need to think about how you're going to prepare. So we looked at, in critical care, the Society of Critical Care Medicine had a wonderful framework on how you can bring in other disciplines to help support critical care, especially people who don't have that expertise. We worked really closely with our anesthesiologists and with the CRNAs. They were tremendous. We have code blues for when somebody's heart stops, rapid response when somebody's deteriorating quickly, and the CRNAs were instrumental. Those events doubled during the surge, so the number of emergency responses to bedsides was just incredible, and they really, really helped us achieve that. In opening up critical care on our CCU, which is kind of like a cardiac step-down unit, it's not an ICU, so we had to put together equipment carts. We put together kits so that people could have supplies and rapidly get into rooms to be able to take care of patients. The CCU nurses who normally did not take care of ventilated patients, we did classes and training with them so that they would be prepared to help out. And Dr. McSuris alluded to there were times when our own staff was sick, and nurses from all over the hospital were able to come in, pick up, and provide really, really great care to the many, many patients that we took care of during this time.
Thank you, Robin. So we started to see our first patients in March. It's August now. Has treatment evolved and changed over time? And would you comment on some of those treatments and whether it's been impactful to our patients or not?
Sure. So, like the rest of the country, we were looking for answers on how to combat this horrible disease. And there's no evidence-based practice, which we're used to looking at, what's the best way to do it. And so we were following along with the top hospitals in this country, learning from them. We tried the hydrochloroquine. We tried that with our patients. We did not find it to be effective as other hospitals reported. We were able to, at some point, start doing convalescent plasma, where we take the plasma of somebody who has had COVID and has those antibodies that Dr. Deng talked about, and give the transfusion to people who have COVID, and that's had a significant impact. We started using the convalescent plasma. We saw our length of stay in the ICU go down, decreasing between 6 and 11 days on average. Normally in the ICU, we see a patient stay maybe between 7 and 15 days on average. Our longest length of stay for a COVID patient was 70 days, and I would say on average we were seeing about 40 to 50 days in the ICU, which was really unusual. You may have heard about remdesivir, which we are also giving to our patients, and we have seen that patients are not getting as sick as often, so that's been helpful. And then we also started using a steroid drug called dexamethasone. So those treatments have been really, really helpful. We are open to research projects that may have a promising effect on our patients. We have a research study that's in progress now with a rheumatoid arthritis drug. So care has changed, but we're doing our best to stay ahead of it, and we are seeing positive impacts in our patients and in their outcomes.
Great, thank you, Robin. How about some of our partner organizations? How do we partner with skilled nursing facilities and LTACs as part of our patient and community response?
We have an amazing director of case management, Beth, and she partnered with you, Dr. McNulty, to really establish relationships with our preferred provider nursing homes, find out what their needs are, and to see how we can assist them. They were really concerned because there were so many outbreaks in the community and in nursing homes, and so we helped review their needs. We brainstormed with them on staffing and other solutions to help them take care of these patients. Whenever we got a roadblock, we escalated to Dr. McNulty or to Anthony, and you guys did a great job escalating to the IHA, to the various elected officials to really help us get resources or help to change policy. We also worked with LTAC. It was really hard for them. LTAC takes care of long-term ventilator patients, which we had a huge number of during this time, and Dr. McNulty reached out, worked with them, and they were able to take some patients from us, which they originally were not willing to take. So it was a really great partnership and a lot of great work from the Swedish team.
Yeah, the one thing I'd add is our partnership with North Shore I alluded to before, and they actually turned their, most of their Glenbrook facility into a COVID hospital, and were able to take about 40 of our patients over the peak of the epidemic, and that was an escape valve that if we didn't have, I think we would have been in even more dire straits than we were with the number of patients we had. So gratitude there. Robin, how about a COVID-specific unit? Do we have a COVID-specific unit? And if so, is that something that will be maintained for the foreseeable future?
We do. We have 2 COVID-specific units. So 7 East is our COVID unit for non-critical care patients, and our IMCU, which is our critical care step-down, has been converted to our critical care COVID unit. So we'll be doing some work to make those rooms better equipped to take care of our patients. We did a lot of things very rapidly as this disease began to surge. So those rooms will be permanently negative pressure, and we'll be looking at, we did some debriefing and feedback from the staff on things that they need to help them take better care of their patients based on what we learned during this time.
Great, thank you so much, Robin. All right, we're going to move next to Greg Gonzaga. So Greg is the Director of Infection Control and Prevention here at the hospital. That's a kind of a huge job in normal times. Obviously, there's a variety of different infectious diseases like C. diff and MRSA, and a variety of different things that you may have heard of and are appropriately afraid of. Add on a pandemic, and Greg and his team, were presented really with a career defining challenge, and Greg and Sean and the infectious disease doctors they work with rose to the challenge and more to help us understand and respond to this, including really helping us run a daily meeting at the hospital where we work to figure all these different nuances out about how we'd respond. So, Greg, a couple of questions for you. One was specifically about playing sports. Again, a lot of talk. We've got professional sports up and going. High school and college sports. It's kind of different opinions in the news every day. Are there any sports that are safe to play? And if so, how do you do that?
Yes. Hi. Good morning. Good afternoon, everyone. Thank you for having me. That's a great question, Dr. McNulty. I think it depends on the type of sport that you're playing and who you're playing it with. Obviously, if you're playing sports with individuals within your household, like your own kids, your spouse, the risk of contracting COVID does not necessarily increase a lot just because you've already been in contact with those people. But I think if you're playing with people that are outside of your household, you don't know who these people are in contact with. The risk would be significantly higher, especially if you are playing a high contact sports. The Infectious Disease Society of America, they kind of publish, the different risk of activities, and tennis and golf, they're considering those as low-risk activities because they are basically non-contact sports. Plus, you could, with golf, for example, you could play with a mask on and you could keep a social distance of 6 feet. With tennis, same thing. Especially if you play singles play, the distance between you and your opponent is far enough that it is safer. But with high contact sports like football, basketball, for example, these are considered high risk contact sports, and I don't really recommend that anyone would play that sport. Now, I know NBA is coming back, Major League Baseball is coming back, but the resources of those organizations are really enormous. They test their players multiple times a week. NBA, for example, they basically house their players in Disney, Orlando. If you go out without any permission, then you would quarantine for 14 days. You would not be allowed to play. I would be very surprised if there's any club or high school or even college schools that have the same resources as these professionals organizations have. So unless you do have the what they call the bubble, if you're able to create the bubble and if you are able to do multiple testing for athletes, I think it's best to avoid the high contact sports, at least until we know how the COVID activity is going to be within the next few months.
All right, thank you. Yeah, and I would echo that. I think what's going on in Major League Baseball just shows even with their resources, two teams have basically tested SWATs positive and have had to cancel multiple games. Greg, a totally different subject. There's a question about the impact of blood type. Initially, there was something about type A blood type maybe as a risk factor, other genetic factors. Do we have any real understanding of what the data shows us there?
Yes, so there was actually a study that was published in the New England Journal of Medicine sometime around late June. And this is a study that was conducted by researchers from Germany and Norway, and it included probably about 2,000 patients that were being treated. These were severe patients that were treated for COVID-19 in about 7 medical centers in Italy and Spain. And what the researchers were able to find was that there were gene variants in 2 regions of the human genome that are associated with severe COVID-19 and correspondingly carry a greater risk of COVID-19 related deaths. The 2 stretches of DNA that is implicated is harboring risk for severe COVID-19 are known to carry some intriguing genes, some of which include the ability to determine blood type and other that play various roles in the immune system. They also further suggested that their findings suggest people with blood type A face a 50% greater risk of needing oxygen support or ventilator should they become infected with COVID-19. And in contrast to that, people with blood type O has a 50% reduced risk of acquiring severe COVID-19 deaths. So this is a study that I think really needs to be expanded, and this is one of those first step to determine exactly the precise underlying genes and the mechanisms responsible for the severity of COVID-19. So I would expect that there would be more studies along this line in the future. But for now, it seems like there is some type of a correlation between blood types and the severity of COVID-19, which is related to a variant genes in the human genome.
So, Greg, thank you. Last question. To sum it up, should I move to Russia? I guess hearing about a vaccine development in Russia should, the leader makes me a little nervous. So, mine does. One of the U.S. does too, but that's a whole conversation. But tell me about a vaccine. What do you think is on the horizon in terms of a vaccine, and will it be safe, and all those questions?
Well, so medical experts in the United States, have widely said that they are expecting vaccines to be widely available in mid-2021. There is a vaccine that is developed by Moderna in partnership with the NIH, and that vaccine entered phase 3 trial. This was on July 27. So they are planning of enrolling about 30,000 healthy individuals at about 90 sites across the United States. So what happens is that they would enroll these individuals, right? And then they're thinking of finishing the enrollment process by the end of September. And then they would give these individuals their first dose. And then they will wait for about 28 days to give the second dose. And then they will wait to see if any of these individuals become sick with COVID-19. So there's a lot of things that needs to happen. That's why it's kind of like very impossible for a vaccine to be available before the end of the year. I know Dr. McNulty mentioned Russia, that they did approve their vaccine, but they also said that vaccine they did not finish their clinical trials. So the safety of that vaccine is really it has really a big question mark. They really don't know if that's safe, and everybody's not really sure as to why they did that, why they approved that. They think that it's because they want to be the first country to approve a vaccine. But for the United States, the clinical trial has to finish. The FDA would then review the results of those clinical trials, and then they would be the ones to approve the vaccine basing on the results of those clinical trials.
All right, thank you, Greg. So I'm going to wait for the Apollo vaccine rather than the Sputnik vaccine. Is that the basic message?
Yes, definitely.
All right. So we're running a few minutes over. Dr. Abbasi is our last panelist. I appreciate those of you sticking around if you can. So Dr. Abbasi is another one of our medical staff members that wears multiple hats. In addition to her medical degree, she has a master's in public health that gives her unique insight into this. She is the medical director of our employed medical group and is also the chairman of OBGYN, so does lots of different things and many different viewpoints here. Two questions that were directed to her. One is just how things have unfolded on our labor and delivery unit and its practices, and then the second is she has a specific interest in the disproportionate impact of COVID on people of color and her thoughts on that and what we at Swedish are trying to do to help that specific issue. So Shamim, if you would handle those two, and then we will wrap up.
Sure. Yeah, so we actually have a couple of research studies going on right now looking at our COVID demographics and mortality rates and the different variables that go into that, as well as in partnership with North Shore, a study that's really looking at health disparities with the Asian population. But what we do know so far is that disproportionately we have seen COVID admissions really be kind of comprised of Hispanics, Asians, and African Americans. So for example, almost 70% of the surrounding population is white, but in terms of admissions, they only make up a quarter. And then of intubated patients, only 20%. And really, if you look at the amount of Hispanics that live in the neighborhood, it's about 25%, but they've made up about 35% of the admissions and over about 45% of the intubations. So there'll be more to come on that, and I think if you look at sort of just death rates in general, it may not really show a lot of disparities, but when you think about the U.S. population, the older population is whiter. If you do a lot of age adjustment, meaning just look at ages 40 to 50 and see what the death rates are among that group, then you'll see the health disparities of Hispanics and African Americans dying. Their mortality rates are disproportionately higher. So I think there'll be some interesting studies coming out of Swedish about that. And I think one of the nice things about North Shore, I think we have a very valuable patient population to describe in the research, and I think we can contribute to the medical research by just really describing what's going on in our patient population here, because it's very uniquely diverse. What was the next question?
OB, just labor and delivery.
Oh, yeah. So, yeah, in OB, we've had probably about 10 COVID-positive mothers since the beginning, which is not a lot. I think, we were expecting more because, in the state of Illinois, 50% of patients are covered by public aid who are pregnant, and at Swedish it's about 60%. And we see a lot of patients from the FQHCs, the Federally Qualified Healthcare Centers of Erie, Family Health, and Heartland, as well as the medical group does have a sizable public aid population. And so, that's the group that is our essential workers. And, it's been surprisingly lower than expected, which is great. And, people do become positive during pregnancy and then recover by the time they deliver. We've had a few transfers over to Evanston for patients that were in respiratory distress and needed intubation because they can deliver patients earlier at Evanston than the weekend because of their neonatal intensive care unit. what else? In terms of, what to do at the time of delivery for a COVID positive mom, when we started, we had very little information on, how this disease affects newborns, and people were very concerned that, because it's such a vulnerable time of life, those first few days of life, that really the recommendation was to separate the mom and baby in the hospital, and, breastfeeding to the breast was not something encouraged necessarily until women were pumping. But really, I think over time that has evolved, and now we're offering patients to room in with their newborns and keep the baby in a bassinet 6 feet away with a clear, transparent, solid barrier. Because really you want to establish safe practices, mask wearing, hand washing, because once the patient goes home with their baby, they're going to have to take care of that baby. And, the typical Swedish patient has multi-generational family members in their, apartment, and, really strict isolation is often not really feasible. So, we're taking a more of a practical approach. And there really isn't any evidence that, newborns can get infected through the placenta. So, that I think is something that's really changed in a short period of time.
Great, thank you, Dr. Bussey. All right, so that finishes the questions that were submitted to us. We are a couple of minutes over. I appreciate panelists and participants staying tuned in. I just wanted to personally end by thanking Jennifer and Jennifer for putting this together, as well as those of you that support our foundation. I know I can, tell you during, the beginning of this, it was really pretty terrifying to be a healthcare worker at a time where we just knew so little about a disease coming our way. And so many people reached out in a whole variety of ways. And I know the truly devoted members of the foundation who support us in so many different ways, did so with financial gifts and cards and letters and meals, and it really was something that helped get us through during a very, very difficult time, because we knew the community, understood some of the pain and uncertainty that we were going through as healthcare workers as we tried to reach out and care for our community. And so, the partnership that we have with those of you who support the foundation is very real and really valued. So just want to express truly my thanks from all of us at Swedish and the foundation for you that help support us in everything we do. So Jennifer, I don't know if you have any further words, but if not, we will wrap it up, and thank you so much for your time today.